Hi, I'm Josie, and Carolyn will introduce herself shortly. Firstly, I'm going to talk about our roles, then a brief overview of our patient group, how we identify complex patients and how we assist them to complete their treatment. So I'd like to pay my respects to the traditional owners of this land and also to Aboriginal people who are visiting, who are here today. So our positions commenced in 2011 and we were funded by CanNet. Currently we're funded by Close the Gap, which is SA Health Government funding, and we're funded for another two and a half years. We both have RN3 positions and work part-time. We're guided by the Aboriginal and Torres Strait Islander companion document to the statewide cancer control plan and cancer care pathways, and that was developed by the Aboriginal and Torres Strait Islander Committee of the SA Cancer Clinical Network. Our roles aim to provide a coordinated experience of care for Aboriginal and Torres Strait Islander cancer patients and their families attending the central Adelaide local health networks for cancer treatment, and the sites are the Royal Adelaide Hospital and the Queen Elizabeth Hospital. So a little bit of an overview about our patient group. This is just for the last quarter in our actively managed patients, or the first quarter of this year. You can see that most of our patients come from interstate and from rural and remote SA. We have about a quarter of the patients live in metropolitan Adelaide. The rural and remote South Australian patients includes the APY lands and regional South Australia, and interstate patients come from the Northern Territory mainly, and that's Central Australia, a few from the top end, and also the Broken Hill and Mildura regions. So these points are what we've found in our roles as how we've identified complex patients. We need to identify the patients because we've found that they're more likely to have poorer experiences during their treatment, and also are at risk of not completing their treatment. So how we've identified the complex patients are those with multiple social and cultural needs in addition to clinical needs, when an Aboriginal language is the first language, because often they'll need interpreters at different points during their treatment, and involve family as well, who may not be in Adelaide but may not also understand the treatment that's happening to their family member. Patients with many treatment providers, and also when someone's treatment needs to be coordinated across several health services, and people living in rural and remote areas generally have more complex needs. So this chart shows the needs of complex patients and how we would assist them. So we provide ongoing clinical nursing assessment, which includes physical and psychosocial needs. And it does need to be ongoing because often it takes a little while to develop a relationship with people, and a little while before people trust us enough to, tell us what's happening and what their concerns are, and for us to find out, where gaps about their understanding of their treatment, etc. is. So we go and touch base when they're coming in for their appointments, ring them up, see what's happening, depending what part of their treatment is happening. So, and we also liaise with the treating medical team. We keep up to date with their treatment and the goals, and we can certainly provide information to the doctors if the patients don't. Often we go to appointments with the patients and the patients don't really explain what's happening, whereas they may have told us, and so we can pass that information on. And then if the patient has questions after they leave the doctors, we can just go over exactly what's happening, and they might have further questions. We do things such as source funding to support extended family to come if patients are in Adelaide for a few months, for example, and we might liaise with the social workers and the Aboriginal and Torres Strait Islander team, and we work with the ATSI team. We work closely with them, of course. We also, really there are just such a huge range of things that crop up. We make referrals to services if we can't deal with them directly. And when someone's finished their treatment, the patient, we certainly coordinate their return home and make sure that they've got the equipment and medications that they need back in their communities. We support the carers when they're here. We assess their needs, and they may have medical and psychosocial needs, including financial needs as well. So we assess them, because if the carer has to leave, well, that puts the patient at risk of not completing their treatment. So I didn't mention before, which I wanted to, about the extent of our roles, because we would see patients when they first come for investigations at times, when that's necessary before the cancer diagnosis. And sometimes we have referrals to do that. And once they're diagnosed with cancer, we can certainly follow people through if they need to have surgery or radiotherapy or chemotherapy. And that's really good that we can do it through. And then when they come back for reviews, we touch base as well. So Carolyn's going to tell you a patient story and a little bit of extra information.
I guess when we're talking, listening to someone's story, I think, is sometimes the best way to highlight some of those complexities in the journey, the cancer journey. And I wanted to share, and obviously I've this is a real story, but I've de-identified it, okay, so we changed names and all that sort of stuff, all right, just for her confidentiality. So I've called her Pamela, okay, and I first came aware of Pamela, I was actually contacted by the gynae-oncology cancer care coordinator at the Adelaide Hospital. Okay, she gave me a call because she'd been contacted by Alice Springs saying they'd had a referral about a woman who had early stage endometrial cancer, so a gynae cancer, and she needed to come to Adelaide for treatment. Unfortunately, after she'd had her investigations at Alice Springs, she was supposed to return for her outpatient's appointment where they were going to tell her about her cancer diagnosis, but she never showed up to that appointment. All right. So the referral had come to Adelaide and she'd gone missing. She didn't actually know she had a cancer diagnosis, okay? So they'd contacted me and said, is there anything you think you can do? And I said, look, I'm going to give it a try, okay? She had early stages. If we can get her back into treatment, this was a curable cancer, okay? So I found out that Pamela was from a remote community, okay? And she was in her 50s. She was a mother of 3. I obviously started with that remote community, rang the clinic there, asked if they had seen her or had any contact with her. They knew her quite well, and they said, look, the last we'd heard, she'd travelled down to South Australia and she was in a regional town of South Australia, okay? So they named the town for me. I thought, all right, I'll ring that town. And there's a large Aboriginal health service in that town. So I rang them and said, by any chance, have you seen Pamela? Because we urgently need to find her. And they said, yeah, she was here, and they knew her quite well as well. And they said, we heard she'd gone to Tennant Creek to visit family. And I went, right. So rang Tennant Creek, spoke to Congress up there. Congress didn't know this lady and said, no, we had no records of her ever presenting here and didn't know. So I'd sort of hit a dead end by then. So I left a message and just said, look, it's kind of urgent. We do need to find this lady. If she does present, please contact the cancer care coordinators at the Adelaide Hospital. I left them my number, okay? Now, a few months later, I get a call from the gynae cancer care coordinator again at the Adelaide Hospital saying, Pamela has presented at the Adelaide Hospital. She presented overnight to emergency, so she was in Adelaide, okay? Unfortunately, she did present intoxicated, so she'd actually come in quite intoxicated, and she'd presented because she was getting ongoing gynae symptoms, okay, as well. So she was drunk at the time, but comes in. And obviously in her file we had the referral from Alice Springs, so the doctors were immediately alerted that this woman had a cancer and she'd been missing to treatment since that time. On investigation, we also found that she had a very low haemoglobin, very low, due to the ongoing symptoms she'd been having, and so she was sitting at about 53. So she was admitted, and I got contacted the next day and asked if I could get involved in her care, and with the care coordinationist lady. So she was planned for surgery, and with possibility of brachytherapy post-surgery, depending how the surgery went. So I went to meet Pamela. And obviously, I mean, she's never met me before, and we know that to build that trust relationship takes time, okay? So I'm not going to go in there and just instantly go straight into coordinating her care without first getting that relationship. And she was initially shy and reluctant to engage, but, you know, over time and with further conversation, we didn't talk about the cancer, we didn't talk about everything that was going on, we talked about her family, and she began to open up. Turned out she spoke very good English, okay? And we were talking, it turned out she was schooled in Adelaide, so she grew up in a remote community, so she had a foot in two worlds, okay? And she'd been schooled in Adelaide, and she lived between both the community and Adelaide. She had talked about her 3 daughters, that they were all currently living remote, how I could contact them, and who was the right person to talk to, and we had that whole conversation. Then she told me that since leaving Alice Springs, that she'd found a partner, she'd met a man. He was a homeless man that lived in Adelaide, and so in the several months that we couldn't find her, she'd actually been living rough in the parklands in Adelaide with her partner, okay? So obviously straight away I'm thinking, right, we've got nowhere to put this woman. She's transient, she's homeless, so this is going to add, like, you know, a big layer of problems there. But she did say that currently she had met there was another man who was living in the park. He'd scored a housing trust house, so many of them that were living in the park that were his friends were now all camping at his house, okay? So there were several of them living there, so it was quite overcrowded. Once we'd got her into hospital and got her transfused and that stuff, we also found she had a bad infestation of scabies as well, so which obviously suggested that current house she was living in was probably overcrowded, and the cleanliness was obviously an issue as well. She had very few belongings. She had very few clothes as well. On talking to her too, it sort of became apparent she had more than one name on file at the Adelaide. She didn't have any copies of her healthcare card or her Medicare card, okay? So first thing was I needed to work out, so we contacted the Indigenous Access Medicare line because I needed to know what was on her Medicare card, what name was on the Medicare card. So we spoke to them, they were fantastic. We tried several different dates of birth, several different names, so eventually we got a match, and we were able to update her medical files using that name, and everything was collated, okay? We got social work reviewed very early, so prior to surgery, social work was involved, and Aboriginal liaison unit. So we had lots of people swinging into action. This was to obviously assess her welfare payments, okay? We also needed to get concession cards and all that sort of stuff sorted out, and also start addressing what we're going to do on discharge, okay? She had other comorbidities, which obviously also adds to the complexity. So she had diabetes, which wasn't very well controlled. She also had a long history of alcohol abuse, and that had led to her getting alcoholic hepatitis, so we also had poor liver function going on. She was a smoker, and she was also overweight, okay? It was decided that we'd keep her in hospital, so rather than, although there was, medically we probably could have discharged her, but we decided if we did, there was concern that we were going to lose her again, that she wouldn't come back. So they fast-tracked the surgery as fast as they could to a week and a half later. She was kept, and we also concerned because she was living in poor living conditions. She was deconditioned as well, and obviously had not been eating well. So this would give us a chance to feed her up, treat the scabies, get the diabetes under control, and also ensuring an optimal recovery post-surgery. That was also our goal, okay? She went on to surgery. They used the Da Vinci robotic assisted surgical intervention, which means you've got a shorter recovery time, which was great. 2 days later, she was planned for discharge. That gave us a couple of days to source some clean and warm clothing for her. And on talking to her, she was fairly insistent that she wanted to return to where her partner was staying in the overcrowded house. And that, I did try and come up with other options, but that's where she wanted to go. She wanted to be with a partner, wanted to go back to that house. So did a lot of education with her about post-op care and all that stuff, and social work assisted with some transport, and we got her back out to the house. So in between all that, I also talked to her about, we have employees in the community team. So I talked to her about them and the type of assistance they would be able to give her, and that there'd be an Aboriginal health worker that would be able to come and pick her up and take her to appointments or to organise her medication. She was happy for me to do that referral. And so we got CTG involved, and a brilliant Aboriginal health worker, Annette, came and got quite involved and visited her at the house and stuff. Unfortunately, we did discharge, and unfortunately she didn't actually last very long out in the community. She did return, I think it was within 8 hours. She was, by midnight that night, she had represented at emergency. She'd come in with quite severe post-op pain, abdominal pain. The problem, and I guess, is that a lot of the stronger pain medicine hadn't been given to her because of her liver function, and also concern of the fact that she had a history of alcohol abuse. The doctors had given her, I guess, a lighter pain relief, so which wasn't really covering her pain. I liaised with the doctors on behalf of the patient, and we were able to obviously address that issue, readdress the medication. We got the pain unit involved with that as well. So that was all readdressed, and we were able to then look at discharging her again a few days later once we got her pain management. This time I was able to convince her to let social work were able to get a hold of some funding, and I said, look, why don't you go stay at one of the Aboriginal hostels just for 1 week while you recover after your operation. You'll get 3 meals a day there, that was all included, and I said you'll have access to showers, and you just spend 1 week there and then go back to the house after that. She did want to get a better living arrangement, so I also referred her to the city homeless team, who were quite familiar with her already, and about seeing what we could do about better accommodation down the track. So she was, so we got her discharged. The community health worker, Annette, spent time following her up and all that stuff. She was to return about a week afterwards to get the results of her surgery. It turned out, had a good result, okay, except she was going to need some brachytherapy, right? So after the appointment, I explained to Pamela what brachytherapy involved. I won't go into, the whole details behind that, but it's fairly invasive and difficult, I guess, for traditional women. Well, I guess for any woman, it's quite a difficult experience, let alone if you're a traditional woman. She said she would come, and with the help of the Aboriginal health worker, but she said, I want to come if my daughter can come with me. And I said, all right, well, we could do it. She goes, oh, it's okay because she's in Adelaide. And I said, excellent. And she goes, yeah, but however, she's detained in a mental health facility at the moment. So, right. So on the phone, liaising with the mental health facility, arranged for day leave, assured her that we'd look after the daughter. The daughter was happy to come and assist us with. So the health worker, CTG health worker, Annette would go to the health facility, pick up the daughter, the mental health, then go over and pick up Pamela, and then Pamela over to us, and then I'd meet them all there and all that stuff. And we managed to get her through. She did miss a couple of her brachytherapy treatments, and fortunately I was working with a fantastic flexible radiation oncologist who just went with it and would just reschedule as we had missed appointments and stuff, and so we did manage to get her through her treatment, okay? Unfortunately after that she didn't come back for her 3-month review. She'd go missing again. So, but interesting enough is that she did eventually ring me, and she has continued to stay in contact with me, and she's pretty clever, and she's managed to go, I think I'm supposed to have seen the doctor sometime about now. And I said, yeah, it was about a month ago, but that's okay, we can get you another appointment. Where are you now? And she'd let me know where she was in Australia. I think half of Australia has her medical records, because she'll go, can you send it to this Aboriginal health clinic so they know what's wrong with me, and when my follow-up is, I'd fax it through to them and give them a call. And a couple of months later, she'd ring me again and would do the same thing with another health facility wherever she was at that point. But I guess the thing that impressed me with this woman is that despite her transient lifestyle, one, she's been able to keep in contact with us, and I guess having that access to the same clinician has made a big difference for her in her journey. But despite all the barriers faced by this woman, that she's been so determined, and that she wanted to get better, and she wanted to beat this cancer, but all she just needed was a little bit of help, And I'm just wrapped that we have been able to provide that service for her. So, and I guess just. It's well documented that that it takes a while for Aboriginal people to gain trust in care providers, and so what we've been able to do is offer that, that in a tertiary big scary hospital, we can offer them this access to the same clinician, and we're like a constant factor for them throughout the journey. So, and again, this has been talked about a lot. It's about a holistic approach. It's like it's not just talking about the clinical, physical needs. It's about looking at the psychosocial needs. It's about the cultural needs, the communication problems that commonly go on, and in many cases, the access issues that patients are having. So our role, and I think where we can hopefully make a difference in listening to a lot of people who are working out remote, that lack of communication between mainstream and community is a big problem. That's something we really try hard to address, and we try to make sure that before these patients are returning back to these communities, that the community nurses and the health workers are aware of the needs of the patient, the discharge planning, when the next follow-up is, all of that is happening before that patient even leaves the mainstream system. That continual education of the patient and that support to the carer, okay, and the education for the carer as well, and how they can help look after their family when they get home. But as I think Pamela's story highlights, that point of contact, just knowing that when she rings up, that we answer, okay, and we know who she is, and we can instantly find the information she needs, and we can get her linked, okay. And that's the same for the family. We're there for the family if they just need to debrief or ring or say we're not coping, we don't know who else to talk to, and we can help get them linked into the support they need. So that's it from us.